Hello Instagram fam, it's Dr. T here on Wednesday night, coming to you at about 8 p.m. It has been a long day and I thought there was moments where I thought I just can't do this, but I know there's lots of you out there that are wanting to ask questions. So we have a short period of time together. Please post your questions. I don't think I had anything on direct message. I may have missed it. So if you did send me a DM with a question for tonight, please don't hesitate to drop it into the comment section. Try and make them as generic as you can, and I'll try and give a nice generic answer, and hopefully everybody on here can take something away from that. Hello, Nicole Harris, Nikita Davis, lovely to see you. Staffy, Mama Me, lovely to have you back. Joanne Henderson, Haffy, good to have you on, Haffy. Vivanya's here. Robert Cat's on. Good to see you. Alana J. All right. Have I got any questions? Is anyone tapping away furiously on the... I don't know why it is, but my dog always insists on playing with inappropriate things right when I'm doing a live. He's playing with the other dog's lead at the moment. Anyway, I've just got to let it go. I'm right here with you guys. Do we have any questions? I'm sitting here trying to rack my brains for, here's someone. Life of Brit. I can always rely on Life of Brit for a question. Are the longer egg sperm embryos frozen, the less quality they are? Do you know what? That's a really, really good question. It is our belief that frozen embryo has the same pregnancy rate as a fresh embryo, and certainly many of us have patients who come back for child number 2, child number 3 years and years later. Not only that, but there are many people that get to the end of their storage life, so in Western Australia that's 10 years, and they decide to donate to others, and the pregnancy rates are excellent. So from an embryo quality point of view, we don't think there's any significant difference. From a sperm quality point of view, we don't really think there's any significant difference either. However, there is questionable data around eggs. There is some data from overseas that shows that the pregnancy rates with people who freeze their eggs are actually better some 2 to 3 years after they've frozen them than longer down the track. So I think we probably don't have enough data on the egg freezing, and that's because it's actually really hard to freeze eggs. Eggs are a much bigger cell. There's a lot more shift of fluid across the cell membrane when you are thawing it and when you're freezing it. And so there's the potential for more damage there. So yes, some data that says maybe if you're going to do egg freezing, you want to use them within about a 2 to 3 year period of time. But again, there's no really solid data on that. Great question though, really good question. Thank you for asking it. Chantel Dewar, how does growth hormone help in egg quality? I've got a low AMH. How does growth hormone help? Well, the thinking is that it improves the quality of the follicular fluid in which the egg is actually grown. And so it's intended for those who have had poor response, and generally those who are older with poor response. So that expected poor response. We don't necessarily think that it applies to younger women who have poorer response, so those who have an unexpected poor response. So there was a really large multi-centre randomised double-blind controlled trial done in Australia and New Zealand a few years ago, looking to see if growth hormone actually improved pregnancy outcomes in women who had previously been poor responder. And the outcome of that study, it's probably about the best quality study that we can do, shows that there is no significant difference in using growth hormone. Growth hormone is very expensive and it's something that you have to take in a daily dose. So it's not something that I ascribe to. Biologically, it seems really plausible. But I guess if you tried everything else, you could try it, but it's not something that I ascribe to. So hopefully that's a helpful answer for you. Melissa Nagoni one. Do I need a tubal patency test before egg collection? No, you don't. Often it depends on what your cause of fertility is. For example, if there was male factor infertility, then I wouldn't bother doing a tubal patency test on you because it's a painful test. It costs a little bit here in Western Australia to do. And if it's actually not going to change my outcome, my plan of management, it's not necessarily a test that I'm going to subject everybody to. So no, it depends on the clinical scenario. Burke Migan, how does having an HCG shot help with recurrent implantation failure in an embryo transfer? So I'm thinking what you mean by an HCG shot is your ovidral clicks that you're having in your luteal phase. So I'm guessing that's what you're asking about. If it's not, please ask the question again. But some clinicians will use HCG to, support or promote the support of the corpus luteum in that luteal phase, so in that second half of the cycle. The theory being that by propping up the corpus luteum, by continuing to stimulate it, it's going to produce that necessary estrogen and progesterone, and maybe even some other chemicals that might be important. We certainly know, or it seems to suggest, that the corpus luteum is really important for late pregnancy outcomes. And so some clinicians will use it. Does the data show that it's any better than using progesterone alone? No, it doesn't. But it's certainly not unreasonable to give it to help support that lining. Haley Bolt, does low AMH mean I could have early menopause? Well, I guess it depends on how old you are, but often our AMH falls along a predicted pathway. And so you can probably hear my family yelling in the background. But certainly if you are young and your AMH is low, then it will have a predicted downward slide over the period of your life, and it is likely therefore that you will have an earlier menopause than the average, which is 51. So hopefully that is helpful. Janet Livingston, lovely to have you on. Dana Kuzo, Staffy Mamma Mia, I can depend on you for a question. After a loss in a DNC, how many cycles do you have to have before you can start again for a collection? For an egg collection, probably not too many. It depends on if you're having a transfer, but there is some data, and it's not great quality, to show that your miscarriage rate is slightly higher if you try to conceive after having a miscarriage. So certainly from a spontaneous pregnancy point of view, if someone has had a miscarriage, we generally would encourage them to have a cycle off before they try and conceive again. Whether or not that is indicated in the ART IVF space, I wouldn't really know the data on that, and I certainly don't think it's unreasonable to move forward with an egg collection. Whether or not you're going to have a transfer, I guess that's up to your individual clinician. Erasmia, lovely to have you on. M. Giorgio, lovely to see you. Sinead, Puncher, Dr. Matt Smith, lovely to have you on. Gabriella, Hayley Edwards. Okay, guys, any more questions? Remember, just drop them into the chat box here. Life of Brit, by the way, I'm looking great. Brit, you can be my friend any day. Thank you. I am feeling fab at the moment. I certainly feel that the brain fog that did linger from my journey last year has finally cleared and the sun has come out. I think I'm also in the roll down to Easter. I'm rather looking forward to a little break. So maybe that's why I'm firing on all cylinders. Burke Migan, does having PCOS mean that you are going to go through menopause later? Well, great question. And in fact, yes, we think that is the case because women with PCOS do have a higher follicle count throughout their life. And so, in fact, that means that when many of us are going through menopause at sort of 51, some even earlier than that, women with PCOS probably go through it on average a little bit later. Does it mean their egg quality is better? No. Age is still the indicator for egg quality, but it just means that at the end of their reproductive life, they've got a lot more that probably aren't normal. Good question though. Andy B11, would you encourage a 40-year-old to do PGT if you only get a couple of embryos? Look, that's a question, that's a conversation I often have with my patients. Should we be considering doing PGT? I guess it depends on what your lead up to that point has been. You know, have you had lots of cycles? Have you had recurrent implantation failure. If you've maybe had just one cycle and you might get only 1 or 2 embryos, it also depends on the cost, doesn't it? So for some centres, it's quite expensive. But if you've just got 1 or 2 embryos, I kind of err on the side of just transfer them. If, however, you've had lots of embryos transferred and they appear morphologically to be good quality, it is a way of determining if we have been transferring chromosomally normal embryos. So it depends on really what the use of PGT is. But you're absolutely right. Generally speaking, we would use PGT-A to, I guess, deselect embryos to achieve a pregnancy in a much shorter time period. But that's a really, really good question. Great question. Guys, these are fabulous questions. Does anyone have any more? Is anyone else feverishly typing away to drop a question in? I'll wrap it up in a couple of minutes. Did I miss any? I'm just going back. See if I have missed anything. I don't think so. All right. Oh, did I miss one there? Nope. Oh, a couple have dropped in. Joanna Henderson. Hi, Dr. T. I DM'd earlier, but I'll ask here. Thank you. Please do, because I must have missed it. How long after salpingectomy, because of ectopic, do you have to wait before doing another natural FET? Is it detrimental to do one cycle after? Probably not. Probably not. We do know in IVF that the chance of an ectopic pregnancy is higher. It just is, as part of going through assisted reproduction. By virtue of you having had one ectopic, your chance of having another, again, is slightly higher. However, in saying all of that, doom and gloom, in the majority of cases, your next pregnancy will be intrauterine. I mean, it just makes sense, doesn't it? If your chance of an ectopic is about 1%, it's a little higher. In an IVF population, there's still more than 90% chance that your next transfer is going to implant into the womb. So I don't think there's clear data about how long you should wait after a salpingectomy. Do I think that it's reasonable to start it the next cycle? Well, again, you want to wait till that pregnancy hormone comes down. Again, if you're talking about a natural FET, sometimes it's difficult to know when you start. But I don't see any reason why you couldn't. Astrid, would you do anything differently during egg retrieval if your patient had ovaries that are deep in the pelvis? Deep in the pelvis or high in the pelvis? If they're high in the pelvis, sometimes it's a bit concerning as to whether or not you might be able to reach them, because we do a transvaginal egg collection. But if they're deep in the pelvis, that's exactly where we want them to be. We want them to be nice and low. And in fact, many people have an ultrasound when the ovaries are kind of only this size, unstimulated. When we're doing IVF, they're like this size, and they're much, much bigger, and they're much, much heavier, so they can fall down into the pelvis. So, yeah, I like ovaries that are deep in the pelvis. They're easier to get to. Burke Megan, I've got 2 more questions here, guys, and 3 more, and then I'm going to wrap it up. How do you know when to stop treatment? Does it come from an FS? You mean fertility specialist? How do you know when to stop treatment? Oh, that's a joint decision, I think. I think there is a responsibility that a fertility specialist has to have a discussion with people who maybe have been going through a lot of treatment as to when is a good time to stop. You know, is it dictated by how you're psychosocially coping with the treatment? Is it dictated by a series of poor outcomes, a series of poor egg collections or failed embryo development? Remembering, of course, that there are other ways to have a family. So I never actually say, let's call it quits, see you later. We would have the discussion about other things, donor embryo, donor sperm, donor eggs, and decide what is right for that couple. But I do think after lots of treatment, there is a point where we have a duty of care to speak frankly about what realistic chances of success there are, and about when patients are ready to move on. Emily Renee, if both parents have the same genetic mutation, does that alter the way IVF ICSI is done? No, it isn't. I'm guessing what you mean is you would intend to do PGT-M, so you're looking for a genetic mutation. We still do IVF. Most clinics will choose to do ICSI treatment to improve the accuracy of the genetic testing. We might stimulate you a little bit harder because we know that we're not going to do a fresh transfer, so the chances of ovarian hyperstimulation syndrome are going to be a bit less, so we can afford to push a little harder because we would like to get as many embryos as we can, because depending on the genetic mutation, there's a fair chance that 25% plus of your embryos are going to be affected by the disease. So we want to get you as many as we can. So they're the sorts of things that we would, I guess, tweak in doing stimulation in the context of PGT-M. And Astrid, last question, would you do anything differently during, we've asked that one. We've asked that one. I think I answered that one. All right, my family is going nuts in the background here. I'm going to have to call it quits, my friends. Thank you so much for all these brilliant questions, and thank you so much to seeing everybody on. This will be my last Q&A of my 50 days of Tamara. Next Wednesday, I will be on an aeroplane flying off into the sunset for a weird little vacation on the beach somewhere else. With palm trees. I want you guys to have a beautiful Easter, and I will see you on the flip side. Please stay tuned to all of my videos that will be coming through. See you soon. Bye. Oh, happy Easter.